Okay, so it's the interpretation of FFA and OCT in PDR and DME, and I thank the All India Ophthalmic Society for giving us the opportunity to present our experience in this. So first is fundus fluorescent angiography, in which involves injection of a dye called sodium fluorescent into the antecubital vein, and this is the fundus camera, and serial photographs of the passage of the fluorescent in the retinal circulation is done. These are the more advanced fundus cameras which we have. And this is how the fundus fluorescent angiogram of a normal retina looks like. You have the arteries filling up, and then the veins, you can see the laminar flow. For a beginner, if the laminar flow is seen, that is the vein, and this is the central retina macula, and you generally have a foveal avascular zone surrounding the central retina. And these are a few fluorescent angiograms which I will show. Since the time is only 20 minutes, so I will be showing only few pictures. This is a color photograph of a new vessel, but if you do the angiogram, you get much more information. You see that the new vessel has started leaking because they have leaky walls. At the same time, you can see these black areas in between the big vessels. That is, all the entire capillaries have been obliterated. So these are the capillary non-perfusion areas you can see even here, which basically has resulted in an outpouring of VEGF, which has led to the formation of this new blood vessels. So fluorescent angiography gives you a much better understanding of the extent of ischemia in such conditions wherein even the new vessel is already obvious in proliferative diabetic retinopathy. And in macular edema also, it tells us about the type of macular edema. This is a diffuse type of macular edema in which no clear-cut microaneurysms are made out, a little bit of capillary non-perfusion areas here. Whereas here in this, you can make out these small dots, which are the microaneurysms, which are focal leaks. So you can aim your laser on these spots. So fluorescent angiogram gives us an idea how to treat and manage and prognosticate all types of diabetic retinopathy. And this is a proliferative diabetic retinopathy, and you can see that the macula doesn't seem to be involved that much, and clinically it seems quite obvious. So in this case, fluorescent angiogram is almost unrevealing because it doesn't give us any new information because of the excessive leakage from the new vessels on the disc and elsewhere. So in such cases, the general ophthalmologist and us also, it's better to avoid asking for an angiogram in which, things are so clinically obvious. Whereas in conditions like this, you see that there's a huge preretinal hemorrhage here. Not much of things going on here, maybe a little bit of hard exudates, but you can't make out anything unusual here. And this is a red-free photograph. And so we really need to know whether we are looking at proliferative diabetic retinopathy. So when we do the angiogram, you can make out the new vessels here, and also so many new vessels which were not clinically obvious have been highlighted here. So the clinician basically needs to use the judgment, his or her judgment, in ordering the test for fluorescent angiography because it's an invasive procedure. And this is also, obviously, this is a proliferative diabetic retinopathy with a new vessel and few microaneurysms and all that. But, it's a good montage, but we would also like to know the extent of peripheral ischemia. So when we do the angiogram, we find that cases here and all where clinically new vessels were not obvious, you can make out new vessels, and these are most probably irmas. So you know the extent of the disease and you can treat effectively by laser. And this is one such condition, one another condition where fluorescent angiography is helpful. This is a patient with nephropathy, diabetic nephropathy, and you see vision is only 3/60. And you have a waxy pallor of the macula, and we really don't know what's going on. Probably the vessels look a little occluded, many cottonwool spots. When you do the angiogram, the macular ischemia is totally evident. You see the parafoveal capillary non-perfusion areas. So this is the reason why the patient has a poor visual acuity. In fact, macular ischemia has been suggested to be a marker of diabetic retinopathy. And of course, there are several shortcomings of FFA apart from the fact that it's an invasive procedure. We have come to understand that there are 4 capillary plexuses in the retina and in the posterior pole especially, and the importance of a deep capillary plexus at the level of inner nuclear layer is increasingly being understood. Whereas fluorescent angiography cannot delineate the deep capillary plexus and cannot differentiate the deep capillary from the superficial capillary plexuses. And also all the microaneurysms cannot be delineated. delineated, and the foveal avascular zone size, which is important for prognostication and to rule out macular ischemia, is not clearly possible many of the time because there's a lot of leakage which confounds the picture. And a very important fact of diabetic macular edema, which is serous macular detachment of subretinal fluid, cannot be delineated by fluorescent angiography, apart from the fact that it's an invasive procedure. These are the shortcomings of FFA in DME. And based on all this, we have moved on to OCT, optical coherence tomography, which has become one of the most valuable additions in the armamentarium of a medical retina specialist. It's a non-invasive, non-contact transpupillary imaging, and it's akin to B-scan ultrasonography, in which cross-sectional images of the retina are produced using the optical backscattering of the light, and all the layers of the retina, and nowadays even the choroid, can be beautifully delineated within a matter of seconds. And the resolution can go up to as much as 1 micron, and it uses near-infrared light. It's totally non-invasive Michelson type interferometer. And we had the initial time domain OCT, which measured the time of flight of light, and now we have spectral domain, which measures the wavelengths of back reflected light, and now we've moved on to SPECT source OCT also. So this is the Fourier domain or the spectral domain OCT. You can delineate more vessels with higher number of scans in a point of time, and it's a 50 to 1,000 times faster than the time domain OCT. And with the patients with media opacities, high myopes, pseudophakic, small pupils, it's much better picturization when compared to time domain. And now we have moved on to SWEP source also, which images the choroid and the sclera very well, because we have come to understand that including diabetic retinopathy, the choroid plays a very important role in the pathogenesis, and we have a better penetration through vitreous hemorrhage, dense cataract, etc. So how do we interpret OCT? We have qualitative analysis wherein we look at the morphology, we look at the contour, presence of abnormal areas, we look at the reflectivity, whether it's hyporeflective, hyperreflective, whether there's any shadowing. Then we look at the quantitative analysis, thickness and the volumetry, and also do a 3D analysis in certain specialized situations. Basically, the colors of OCT are all false colors, and bright colors like white and red suggest highly reflective structures, whereas dark colors like black and blue, especially when there's just fluid, that is shown as low reflectivity, and intermediate reflectivity is shown as green. This is almost similar to a corneal topography, as you can see. These are high reflective, and this is low reflective, and the green is middle reflective. And normal foveal profile, we are expected to see a good foveal depression. And this is a preretinal area, this is the epiretinal area, intraretinal and subretinal areas. And the preretinal profile also is important in diabetic macular edema. We should look for tiny dots which can signify vitreous hemorrhage, or an epiretinal membrane, or a preretinal membrane, or a vitreomacular traction. All these things we should look out in the preretinal area. As you can see, this is a cystoid macular edema in a diabetic patient, but there's vitreomacular traction as well. So the treatment changes. We need to do vitrectomy to treat this condition. And this is a diabetic macular edema, and this is a taut posterior hyaloid and an epiretinal membrane, and there's a cystoid macular edema. So these patients may need a possible surgical removal later in case they don't respond to intravitreal injections. And there are several protocols that we follow. We have radial lines, raster lines. We do a macular thickness map. And generally, the radial and the high definition line scans we employ quite a lot. And we generally tend to avoid interpreting the scan in false colors. We go to the black and white, or sometimes white on black mode also, to understand the pathology better. And in tomography and diabetic retinopathy, the OCT, we can talk about diabetic maculopathy, wherein which we can delineate diabetic macular edema or DME, or diabetic macular ischemia or DMI. And peripheral retinopathy also OCT can talk about, give us an idea about capillary non-perfusion, neovascularization and tractional detachments, how to manage, etc. I will be showing a few illustrative examples. And initially, DME used to be classified as clinically significant macular edema and non-CSME in the ETDRS era. Now we have moved on. OCT has been a game changer. We classify DME as center-involving and non-center involving DME. And based on the OCT morphology, we classify it to a spongy swelling, cystoid macular edema, serous detachment, and taut posterior hyaloid membrane. This is a diffuse sponge-like swelling of retina. These are the cystoid spaces with the walls. And here is a clear-cut cystoid macular edema with lot of septate. And this is another entity which can be imaged only by OCT. This is a serous macular detachment, SMG, or subretinal fluid, SRF. It basically indicates chronicity, and that the RP pump, this is the RP layer, and you see that it's quite thin. It's basically sick. It means that it's sick. It's got a guarded visual prognosis, and usually patients have nephropathy or uncontrolled hypertension or anemia or long-standing diabetic macular edema. So by looking at the OCT itself, you can prognosticate what else the patient can have. And subretinal fluid basically, however, is suggested to have a protective role based on RESTORE, RISE and RIGHT studies, and it predicts a better visual acuity gain and the fewer injections over a period of time. And it also probably indicates that the patients with SRF and diabetic macular edema may respond better to anti-VEGF injections. And quantitative 3D maps also, if it is red, that means it's definitely the thickness is increased when compared to yellow or green or blue. Blue, in which it means the retina is thinned out. So there are certain scenarios in which OCT obviously obviates the need for FFA. You don't need an FFA. This is a diabetic patient with chronic renal failure, vision only 2/60. Some hard exudates are there, but why is the vision so poor? You do an OCT, you can't do an angiography because the nephrologist is saying no. So you see that there's so much of inner foveolar thinning with deep retinal exudates. So this patient's visual acuity is unlikely to improve much. So no intervention. And in tractional detachments also, OCT gives us an idea about the extent of TRD, helps us in the treatment. For example, this patient, little bit of traction here, you can see, but there's a cystoid macular edema. The foveola actually seems little okay. So you just manage this patient with anti-VEGF injections. Whereas this patient, if you see a 57-year-old gentleman, lot of pre-retinal hemorrhage, you don't know whether to just do laser, a little bit of fibrosis here, or go ahead and operate. And this is the final picture, but let me tell you how we reached there. This is the OCT. We just directed the OCT to the supratemporal quadrant TRD complex, and you can see that there's a huge TRD complex pulling the retina. And this foveola, you see, is so thinned out with so much of cystoid spaces. So if we don't operate much, there is a risk of operate fast. There is a risk of de-roofing and an inner lamellar hole formation. So we did a careful vitrectomy, did not do an ILM peel, and the patient was how we saw that in the previous slide. And nowadays, we have a lot of excitement about OCT biomarkers in DME. And why do we need that? Because we have found out that central retinal thickness is not a very good indicator of how the patient is going to progress. And there's only a modest correlation of the visual acuity with the DME. And OCT biomarkers can mark the presence, pathophysiology, and prognosis of DME. And as you know, these are the 10 layers of the retina, and all are beautifully illustrated in the OCT. And I'll just take a little time in this. This is the nerve fiber. This is the internal limiting brain, the nerve fiber layer. This dark area is the ganglion cell layer. These two white lines for the dark area in between are what are important for us. And I'll be telling you why. This is the inner plexiform layer, and this is the inner nuclear layer, and this is the outer plexiform layer. This actually represents the metabolic circuitry of the inner retina. So the health of this is very important. And when you look at the OCT, if you see these two white lines with the black area, that means inner retina is relatively fine. And in the outer retina, we have this external limiting membrane, and you have two brightly reflective zones. This is the inner high reflective zone, which previously was thought to be the junction between the inner and outer segment of the photoreceptors. Now we think that it is most probably the ellipsoid layer. And this is the outer segment of the photoreceptors, this hyperreflective zone. And this is actually the interdigitation zone between the outer segment of photoreceptors and the RPE. And this is the retinal pigment epithelium layer. And this is the choroid, and this is the Bruch's membrane. And this is, of course, the outer nuclear layer. And if you see the outer retina in greater detail, the inner segment of the photoreceptors has got the outer ellipsoid and the inner myoid. And this is what is seen in greater detail, especially in swept source OCT. You can make out the ellipsoid zone very well. And this is the RPE Bruch's membrane. And this line on top of the RPE is the interdigitation zone and this external limiting membrane. So this external limiting membrane and ellipsoid zone's integrity are very important. And nowadays we have started looking at these areas in greater detail in diabetic macular edema. So these are all the different markers that we look at: the intraretinal cyst, the ELM integrity, the drill, hyperreflective dots. Now, let me just talk about hyperreflective dots, better seen on white on dark OCT angiograms. You see these dots, they can be present all over in the deep as well as the inner retina. And how do you distinguish from hard exudates? Hard exudates are generally larger and they have some shadowing, especially if they are quite large. This is a typical hard exudates, whereas these are hyperreflective dots, which are small and they don't have much of a shadowing. And there is another important entity in OCT called drill, which is basically the horizontal extent in microns, wherein you can't distinguish the boundaries between the plexiform layers and all that. And within the central 1 millimeter wide area, drill is looked for. For example, this CME looks more extensive, but you can see that this area has got drill, whereas here you can make out the two whites with the black in between. So this patient will generally do well when there is no drill, disorganization of inner retinal layers, whereas this patient doesn't do so well following treatment. And this is one such patient. Despite a huge cyst, you can see that here there's not much of drill, and this patient does quite well with flattening of the cyst following intravitreal anti-VEGF injections. So also loss of parallelism by a specialized software of the outer retina, as well as we also look at the presence of epiretinal membrane in which the whole treatment of the macular edema changes. This is before surgery and this is after surgery with a well-restored foveal contour. And also we, as I told you, we look at the external limiting membrane and ellipsoid zone at DME. And we'll also look for outer retinal tubulations. In contrast to cystoid faces, the border of outer retinal tubulations, which suggest chronicity and a poor prognosis, are hyperreflective. So we look at that also. And this is a very good article. You can go up and look at it. It's an overview of the OCT biomarkers in DME and also cumulative risk factors, like for this patient with a thin outer retina, huge cysts, drill, hyperreflective dots here and there, and an epiretinal membrane. This patient is not going to do well at all. And also we have started looking at the choroid, diabetic choroidopathy, choroidal vascular density and volume, and choroidal vascularity index, which is ratio of luminal area to the choroidal area, again done by a specialized software that is supposed to be decreased in diabetic patients even without retinopathy. Just briefly about Ocd Angiography, which detects the motion of scattering particles like red blood cells, and it's the latest. The newest SD OCT systems and web source OCT systems talk about OCTA. The most exciting thing in diabetic retinopathy of optical coherence tomography angiography is that we are able to look at the superficial and deep capillary plexuses. And if you see, this is an angiogram, whereas this is an OCT angiogram, gives us a much better information. And you can demonstrate microaneurysms in all these findings, just as in an FFA. Of course, it's rapid and non-invasive when compared to an FFA, but doesn't talk about the blood retinal barrier states. You can't get an idea about the hot disk, and we don't have wide field OCTA now, so peripheral CNP areas cannot be delineated. And even in patients without diabetic retinopathy, OCTA has showed a statistically increased FAZ enlargement. It has been suggested to be used as a screening tool. We also tried in some of our patients. This is a patient without diabetic retinopathy. As you can see in the OCT, where the FAZ was enlarged. And you can also measure the size of the FAZ by angioanalytics. And this is the superficial plexus and the deep plexus. In fact, deep plexus ischemia is supposed to be a poorer prognostic factor in DME. And as I said, by angioanalytics, we can measure the extent of the FAZ involvement. And the FAZ size is also correlated to the peripheral ischemia, and it is suggested that an irregular FAZ predicts significant peripheral ischemia and disease severity. And this is a very good paper by Lee et al. In Ophthalmology 2016, wherein they say that deep capillary plexus, the loss of microaneurysms, actually corresponds to the loss of the discontinuity in the synaptic portion of the outer plexiform layer. In fact, the deep capillary plexus is situated at the inner border of the outer border of the inner nuclear layer. So you see that this patient has got the continuity of the outer plexiform layer and not much of a DCP distortion, did very well following anti-VEGF, whereas this patient had discontinuity of the inner plexiform, of the outer plexiform layer, and a DCP which was much widely involved. So this patient did not do so well after anti-VEGF injections. And why? There are several reasons why the DCP loss translates to anti-VEGF responsiveness. And PDR also, OCTA talks about several type of new vessels wherein we can image the MVTs beautifully like this and also document their regression. And there are several advances also, like the VISTA algorithm and the quantitative OCT and the wide field OCTA. So thank you very much for your patient hearing, and we will have I'm sure, a very good discussion to follow. And I will stop sharing my slides.